Okay, today I'm going to talk about atrial fibrillation and atrial flutter. These are very common arrhythmias in cardiology, but they are often confused, especially when we look at ECGs. They are also frequently asked about in real exams. So in this video, let's focus on what they have in common and how they are different using a simple schematic. First, an important point, both atrial fibrillation and atrial flutter are arrhythmias that originate from the atria. Here, this is a sinus node, this area is atrium, and this area is ventricle. In normal sinus rhythm, electrical activity starts from the sinus node and spread in organ way through the atria and ventricle. On ECG, this appears as a normal P wave, QRS complex, and T wave. These are very basic concepts. If this is not clear, please check my other video where I explain normal ECG in more details. Now let's look at the atrial fibrillation first. Atrial fibrillation is caused by many small electrical origins in the atrium, especially around pulmonary veins. Normally there is no ectopic electrical activity in the atrium, but in atrial fibrillation, multiple abnormal impulses are generated at the same time. Some of these impulses reach the atrial ventricular node and intermittently stimulate the ventricle, which leads to irregular ventricular contraction. So what happens to dynamics? Because the atrium is continuously stimulated from many different directions, it cannot contract in a coordinated way. As a result, atrial kick is lost. This reduces cardiac output, especially in elderly patients or in patients with diastolic dysfunction or mitral stenosis. On ECG, there is no consistent P wave. Instead, we see fibrillatory waves and ventricular contraction occurs irregularly. This ECG pattern represents atrial fibrillation. There are many conditions that can trigger atrial fibrillation, such as infections, electrolyte abnormalities, hyperthyroidism, valvular heart disease, and heart failure. When we think about treatment, addressing the underlying causes and triggering factors is of course essential. Without correcting these factors, long-term control is difficult. On top of that, treatment has several important components. First is rate control. Beta blockers are commonly used because they slow atrial ventricular nodal conduction and reduce the ventricular response. Second is anticoagulation. The most important complications of atrial fibrillation is embolism, especially ischemic stroke. Anticoagulation prevents thrombus formation, and the indication is determined by the CHA2DS2-VASc score, not simply by the presence of atrial fibrillation. Third is rhythm control, where appropriate. Recently, catheter ablation, especially pulmonary vein isolation, has been used much more frequently than in the past. Before moving on, let me briefly explain why intervention for underlying cause is so important in daily practice. First, infection. Fever and systemic inflammation increase sympathetic tone and often trigger atrial arrhythmias. If a patient has pneumonia, a urinary tract infection, or sepsis, treating the infection itself can significantly improve rate control. Second, electrolyte abnormalities. Hypokalemia and hypomagnesemia are common and easily overlooked triggers. Always check electrolytes and correct them early, especially in patients with persistent tachycardia. And third, heart failure. Volume overload and elevated atrial pressure stretch the atrium and promote arrhythmias. In these patients, diuresis and optimization of heart failure treatment are essentially parts of both rhythm and rate control. So remember, treating atrial fibrillation is not only about beta blockers, anticoagulation, or ablation. If you don't address the underlying triggers, control will always be unstable. Next, let's talk about atrial flutter. Atrial flutter is caused by re-entry of electrical activity in the atrium. Electrical activation circulates along a fixed pathway, most commonly around the tricuspid valve. Because of this stable re-entry circuit, the atrium is stimulated in a regular and constant pattern. On ECG, atrial flutter shows P wave with the same shape repeatedly. This creates a characteristic sawtooth pattern. The atrial rate is usually around 300 beats per minute. We often describe atrial flutter using conduction rate. For example, 4 P wave for 1 QRS is called 4-to-1 flutter, and then 2 waves for 1 QRS is called 2-to-1 flutter. Because ventricular contraction can be first, atrial flutter may cause tachycardia, syncope, or hemodynamic instability. The causes of atrial flutter are similar to those of atrial fibrillation. However, there is an important difference in treatment strategy. Rate control with oral medication is often difficult in atrial flutter because atrial activity is very fast and regular. On the other hand, catheter ablation has a very high success rate, and atrial flutter is often curable with ablation. It is also important to remember that atrial fibrillation and atrial flutter often coexist. They can convert into each other, and the same patient may experience both arrhythmias over time. So let's summarize the key differences. Atrial fibrillation is caused by multiple ectopic foci, often near the pulmonary veins. P waves are absent and chaotic. The RR interval is irregular, and the heart rate is variable, often between 100 and 170 beats per minute. Atrial flutter is caused by a re-entry circuit, usually around the tricuspid valve. P waves are regular and identical. The RR interval is regular, and the heart rate is often around 150 beats per minute with 2-to-1 condition, rather than 100 or 75. Treatment strategies are similar, including rate control and anticoagulation based on the CHA2DS2-VASc score. However, ablation is used more aggressively in atrial flutter because medication alone is often insufficient and ablation is highly effective. Finally, I want to review with one important message. Sometimes it is difficult to distinguish atrial fibrillation from atrial flutter based on ECG alone. In that situation, check the pulse monitor and focus on heart rate variability. A variable heart rate suggests atrial fibrillation, while a constant heart rate suggests atrial flutter. This is exactly how I teach residents in daily clinical practice. Thinking I understand and actually being able to explain something are very different. If you truly understand atrial fibrillation and atrial flutter, you should be able to draw this schematic yourself and explain it in your own words. Doing that is much harder than just watching a video, but that difficulty is exactly what separates recognizing patterns from having knowledge you can actually use. So don't just memorize. Write it down, explain it, and practice using it. That's how you move from thinking you understand to actually being able to use this knowledge in real clinical situations. Stay calm and act first. I see you in the next video.